Hello, everyone. Thank you so much for being with us today. My name is Rose Gerber. I'm the Director of Patient Advocacy and Education for the Community Oncology Alliance. As I do with every advocacy chat, before I introduce our guests, I'd like to give you a few COA highlights and updates. For those of you who attended our recent incredible 20th anniversary, I'm jumping ahead of myself, COA conference in Florida, you now have access to the presentations. That's, of course, if you registered. And all of you should have received an email with the link. If not, you can find that on the COA website. And I know that following every COA conference, or even probably with today's advocacy chat, we always get requests for, can we do the presentations? So now you have access to that. And speaking of our website, once you're on our website, I always like to encourage you to visit our news and update section. And in this case, specifically the press release section. Just a few days ago, COA did a press release on our support of the recently introduced Strengthening Medicare for Patients and Providers Act, HR 2474. This important legislation would help physicians in rural, underserved, or low-income communities continue to stay open and care for patients at a time that the cost of running medical practices has increased significantly due to inflation. And as we've talked about this topic before in previous chats, it's often very hard to wrap our head around the fact that a cancer center, community oncology practices, are small independent businesses, sometimes large, but still an independent business. You think about the nurses, they're actually employees, the chemo chairs that we sit in, somebody needs to order those chairs. There's costs in providing care. So it's important that we keep on top of these important pieces of legislation that benefit patient care. Now it's time for today's advocacy chat topic. April is National Minority Health Month, which is a perfect opportunity to remind everyone that COA remains committed to the topic of health equity. We're trying to educate not only our membership and share resources, but also all of you. In fact, what we all hope for is that there's equitable treatment for all in everyday life, but especially in cancer treatment. When I was sharing this advocacy chat on my own LinkedIn page, I said, we want there to be equal treatment for everyone, but sadly, we know that there isn't. And today was a perfect day to invite our special guest, Audrey Davis, who's a Director of Health Equity for the highly regarded cancer support community. And today, Audrey is going to update us on what's happening in this area, and also just to overall share her expertise with us. So welcome, Audrey. We're so happy to have you with us here today.
Thank you, Rose. I am so grateful for the opportunity to chat with you more, not only about the work that CSC and COA are doing, but also about advancing health equity for all cancer patients and also their loved ones. With that in mind, if we could share the deck, please. Thank you. I want to start with an analogy. Sometimes people will conflate health equity with equality. And so when we talk about health equity, what we mean, according to CMS, is the attainment of the highest level of health for all people, regardless of what they look like, regardless of their religion, their gender, their sexual orientation, how able-bodied they are, their disability status. We are talking not only about whether their geographic location has an impact on how they'll be treated, but also socioeconomic level, educational, etc. So the analogy that I like to use to help people remember that we're not necessarily just talking about equality, but actually equity is this. Picture yourself on a bicycle. You are at health status A. You want to get to point B. You want to have that highest level of health attained. But in order to do that, you need the right bicycle that's specifically for you. If I were talking about equality, that every single person would get the same exact bicycle, have 2 wheels, handlebars about yay high, and would all just be riding that bicycle to health status B. Whereas if we're talking about equity, then I'm going to be looking at each individual person and I'm going to be saying, this person actually might need handlebars that are a bit higher. This person might need tires that are actually a little bit thinner. This person might need a bicycle that has 3 wheels, instead would do better on a tricycle, but can still get to that next health status point. I want us to think of that analogy as we're framing today's conversation, because again, we're not just talking about equality, we're actually talking about equity so that each person is able to have that fair and just opportunity to get to their highest level of health treatment. Next slide, please. Thank you. At Cancer Support Community, our mission is pretty straightforward. We are the largest professionally led nonprofit network of cancer support worldwide, and we are dedicated to making sure that all people impacted by cancer, and when I say all people, I don't solely mean patients, I also mean caregivers and loved ones. Anyone who has been impacted by cancer is both empowered by knowledge, strengthened by action, and also sustained by community. Next slide, please. Today, we'll be talking about a few things, and the objectives are pretty straightforward and listed here in a sense. I would love for you to be able to walk away with a better understanding of the contextual history involving health-related social needs and what we're talking about. We talk about socioeconomic factors and how cancer patients in particular are affected. I also would like for you to have a better understanding of a model for addressing these health-related social needs, as well as what our efforts here at CSC, Cancer Support Community, are in these spaces. And I'd like to be able to chat more with Rose so that you have a better understanding of what COA is doing to advance health equity as well. Finally, a call to action. I'm going to share some resources with you, some links that you can follow for next steps if you would like to learn more about advocacy work that CSC is doing. If you would like to participate in some of the research that we're engaged in, we would love for you to be involved. Next slide, please. So let's talk about the contextual history here. I love to look at Maslow's hierarchy of needs because I think it crosswalks really nicely. Maslow was concerned with how folks would be able to attain their highest level of self, their optimum level of functioning, and health equity talks about the highest level of health, right? So self versus health. In this hierarchy, it's pretty straightforward. Physiological needs come first. If I'm worried about where I'm going to sleep, or the next meal that I'm going to have, or whether I have access to drinking water, then it's going to be pretty difficult for me to reach the top of that pyramid where I can become all that I can be. A nuance here that I like to point out, Rose, is that for communities of color and for those who have been historically medically underserved or under-resourced, some of these more abstract concepts towards the top of the pyramid are also difficult to not only attain, but also to jive with. We're talking about healthcare professionals, things like respect, things like strength, recognition, even a sense of community or belonging. It's not that folks from these communities don't have that in their communities, but when attempting to interface with healthcare organizations, professionals, often the perception and the assumption about members of these communities is not positive, and so it is difficult to attain that high level of health in this sense. Did you have anything that you thought you would add in terms of what Maslow's hierarchy started with when it comes to what cancer patients are experiencing?
Absolutely, Audrey. I think it's just so powerful when you talk about the most basic needs: air, water, food, shelter, and sleep. Health equity, one of the things I've learned working for COA the last 12 years, and it really shook me to my core, was how many cancer patients are struggling with basics. So they can't even think about getting chemo and radiation and surgery. They're literally trying to get food. I've known people struggled accessing food. I never knew the name food insecurity. People are looking for basic funding to put gas in their car to get to an appointment. So oftentimes when we think of patients, we're thinking about the treatment right away. But this is such a powerful reminder that those basic level needs are what cancer patients need. And then, as you just point out with self-actualization, once they're in front of a provider, how are they being treated? Is that provider seeing them as a cancer patient or viewing them somehow differently because of the color of their skin or anything else that they might just be projecting onto them? So this is a very powerful slide.
Great. Thank you for your thoughts. And I 100% agree. It really, and we can advance to the next slide. Thank you. We can look at this from not only the perspective of Maslow's hierarchy, but crosswalking it again with health equity, right? CMS in 2017 came out with the Accountable Health Communities model. And what they did was they developed a health-related social needs screening tool. Some of the folks on this call might be more familiar with the term social determinants of health, or SDOH. Health-related social needs, basically the same thing. So we're looking at things in the screening tool like housing instability, food insecurity, transportation, help with utilities, and also interpersonal safety. You can advance a bit more in the slide, please. We're also thinking about things not only that are listed in the Ruby pyramid here, but also concerns such as financial strain, also employment, family and community support, education, physical activity, substance use, mental health, and also disability or disability status. Next slide, please. What I want to point out here for cancer patients in particular are just a few examples that I can give you from research about what we know the needs are of our patients and how we are or not meeting them and things that we can do. You can start to advance the slide, please. So when we look at things like utility help, transportation, going food insecurity, and housing stability, we know that these are more of the basics that are screened for in the tool. But the reason that these additional categories were added a couple of years into use of the screening the tool by CMS, added, thank you, like financial strain, employment, physical activity, substance use, mental health, disabilities, or because of how they're interconnected, right? So for example, if I am experiencing financial strain or financial toxicity, which we know is defined as the problems that a patient has with respect to the cost of their medical care, which can ultimately lead to death or bankruptcy, which we see a lot for cancer patients. If I'm having problems with financial toxicity and my employment is adversely affected because of the fact that I have to go to treatment or because I am not physically well enough to be present at work, then things like my housing stability and food security will also be affected, right? If I am not as mobile as I used to be because of side effects of treatment, or even in survivorship because of other diagnoses and conditions that have come up, then I may also have issues with transportation and have issues with employment and have issues with mental health or even substance use. I want to just take a minute or so to share some of the research that we do about. Cancer Support Community has our very own Cancer Experience Registry, which is actually a survey that we conduct of cancer patients and caregivers. And what we know from our own registry of patients surveyed is that in the past year, nearly half of the patients surveyed experienced financial toxicity. 1/3 of those patients actually depleted their savings, and about a quarter of them surveyed had to use retirement funds towards the cost of their own cancer care. This is astonishing. It's also haunting and really disappointing when we think about it. If I'm having to dip into my retirement savings, or I'm unable to pay for my care, or I've completely depleted my own savings, how does that affect these other pieces of the pyramid, right? How am I going to stay in my home if I literally have no money left? I'm primarily focused on my cancer treatment. I also want to talk about from a race-based perspective some of the research that exists. So the Journal of Clinical Oncology noted that Blacks, Hispanics, and non-whites had lower insurance rates than their white counterparts. But it's not just that they had lower insurance rates. Black patients, for example, were also 5 times more likely to be denied insurance and twice as likely to experience financial toxicity. So we're not just talking about the health-related social needs of cancer patients in general, which are important. We're also, again, looking at how someone's skin color or their gender or other factors lead to even more negative effects and make it difficult for them to ride that bicycle onto the higher level of health status point B because of the barriers that are in place. The research has also shown that, for example, in breast cancer patients, Black women and English-speaking Latinas are more likely to experience difficulty with paying for utilities and to experience housing insecurity as a result of financial toxicity and hardship related to medical expenses. This is really concerning, and I could go on and give other examples related to employment or substance use or mental illness, but I think what will drive the point home is just to say that for each of these categories, even if you're not just considering the typical cancer patient, we say typical, let's go with Anglo-Saxon, right? And what we might consider in our minds as not from a community of color, even though we know that the numbers and the prevalence rates actually differ there. If we consider how those other labels and phenotypic factors affect someone's treatment, we also have to think about how the access to the solutions for these health related social needs are affected. And with that, I'm going to pause. I don't know if there are any questions in the Q&A, or Rose, if you had any comments, but I want to make sure that this is indeed a conversation and not a didactic lecture.
We do have a question. So let me get to that question first. And the question is, I'm going to just read you the question as is. The individual has written, I work as an advocate at our Cancer Institute, and I have found that when grants are open, a lot of times it is through health equity, which I've never been able to see where the patient is covered by zip code. Why is that? I'm not sure that I really understand the question. Is maybe the individual is looking to find out zip code information on who's receiving grants. We're willing to, if you want to clarify that, we'll try to answer that for you, and
Yeah.
we'll.
Yeah, I mean, I would also appreciate a bit more clarity related to the question, because we at CSC, we are not a funder. We actually go ahead and pilot projects to address health inequities actually and advance health equity. So I'm not sure why a funder might be interested or not interested in zip code information. I will say that if we're talking about with respect to public health and an approach to health equity, you do have to also look at the built environment, right? Not only the built environment in terms of clean air and drinking water and things like that, and access to even playgrounds or greenery and parks. Research has shown that if you have, an environment around you that is not just concrete buildings, but actually has nature in there, it has positive impacts on your mental health and also physical activity. But also in terms of how your zip code might impact your access to care, your access to a cancer center, your access to other resources that would then help you attain that next level of health status. I think that's what you're getting at, but I'm not 100% sure. I don't know if there's been clarity provided in the chat.
Well, also too, Audrey, I think speaking of clarity, I think what you mentioned right now in terms of cancer support community not being a funder, this is also something that we try to achieve with this advocacy chat, is that there's a lot of different advocacy organizations, and we each have a different organizational focus, but our combined efforts are very powerful. So for example, cancer supports community, your registry, your cancer experience registry is well known, and the information that you get from that registry is incredibly powerful. But now there's other organizations that might be responsible for the funding. And that's just a perfect example of how, something I always say, and I know that many of you believe as well, is that we're stronger when we work together. And let me see if we have clarity on that one question, or if we also have another question. Okay, let me see that. Okay, it looks like we've got a comment that says, makes sense. Some of the 501c3 charitable copay foundations are establishing copay assistance programs like these high health equity funds, in addition to their standard disease funds. This is in relation to 501c3 charitable copay assistance foundations. Thank you very much for your comments and for your engagement as well. Audrey, go ahead.
Definitely. So in the interest of time, what I'm going to ask is that we advance the next slide, but we're actually going to move ahead to the slide after it. This will be in the deck for your review after the presentation, but I want to really spend some time here talking about what can be done. We know that these health-related social exist. We know that there are disparate impacts for people from communities of color, living in rural areas, the LGBTQ+ population, and others. But what can we do to mitigate this? That was a big part of the conversation today. And so you can advance to the next point, right? First thing, it's important to conduct and engage in research, right? We can't, as practitioners or as clinicians or as healthcare professionals, talk in rooms and silos about what we think to be done. We need to be able to actually conduct research, get some qualitative and also quantitative studies going to be able to say, okay, this is where these are the problems that have been identified. We know this, but these are the solutions that are most likely to work. And you could advance the next point, please. And with that, communicate, right? Communicate not only with each other in the professional sense, but communicate with patients and caregivers and others who have this rich lived experience, who can really contribute to our knowledge base in terms of what needs to be done and what would actually help mitigate these factors. You can advance things. In addition to that, with the communication, again, the collaboration there. It's not enough for me to be sitting at a table with other professionals to talk about pilots and projects, programs. I need to be able to be pulling up chairs, multiple at the same table, and having other people have as much of a voice, if not more of a voice, because they actually have the lived experience to be able to say, yes, this works, this doesn't work. By the way, we've already done this, tried this, but thank you for your thoughts, right? To be able to have that accountability there with collaborating with community-based organizations, faith-based organizations, other advocacy groups, other nonprofits, and of course, healthcare organizations as well. You can advance next. Navigation is so important in this space. If we're going to talk about health-related social needs and barriers and access to care, we also need to talk about the solution involving not only proactive navigation, but needs navigation specifically as well. And I'll get into that a bit more and sharing what CPAN does, and you can move on to the next point, please. And of course, part of why we're here today, right? Advocacy. We can do the work that needs to be done with communities of color, with communities who have been historically medically underserved and under-resourced, but we also need to be advocating at the legislative level for policy change. We need to ensure that the systems and structures that have been put in place that have disenfranchised these folks are dismantled, and we do that in one way through advocacy work. If you could move on to the next slide, please. And so I'm going to just share with you a couple of the things that CSC does in order to address these health-related social needs that I mentioned. We have our cancer support helpline, which, as noted here, is 100% free. It is personalized for each caller. It not only serves cancer patients, but also caregivers. We are able to provide referrals to specialized navigators in things such as CAR T cell therapy, as well as financial, pediatric, trials, genetics, and genomics. If you have questions about transportation services, support groups, counseling, and other resources and programs, some of those health-related social needs that I mentioned, not only transportation, our experience in food insecurity, housing insecurity, we can connect you to local or even national level resources to help you get the care that you need on the socioeconomic needs level, but also to ensure that you're able to focus on your cancer care. We are not only available via phone, but also via chat online and also via video. I really, really appreciate the fact that our navigators are not only licensed clinicians, but they're diverse as well. We have at least one Spanish-speaking navigator, and we are able to not only talk with you, but also follow up with you, which I think is really important. Next slide, please. In addition to that, our website has a lot of patient and caregiver resources. These are award-winning materials that do address a broad range of topics here. I love that it's set up like a virtual home. And so literally when you're looking at the webpage, you have different rooms in the home. There's a kitchen, which focuses on things such as healthy recipes that you can use. There's also a library with resources. There's a mind body studio with videos for yoga, things like that. There's a support room, and there's also an action center. And earlier in the purple pyramid, we talked about physical activity concerns. We talked about mental illness. We talked about substance use. The different rooms in this virtual home can help address some of those health-related social needs and concerns as well. Next slide.
Audrey, I have to, say to the audience as well, I love the Cancer Support Community website. I love Cancer Support Community in general. And personally and professionally, I've always referred to your organization because, as I mentioned earlier, your organization provides some services that CPAN was never designed to do. But we definitely, just the way you're suggesting to the audience, this is a resource for all the advocates out there to share with others. This is how we expand our reach. It's always about amplifying the patient's needs, amplifying the advocate voice. And this is the way. No one organization can do it all. And really, I truly think you do a fantastic website for fantastic work for patients. And your website is one of the best.
Thank you. I really appreciate that. I also want to note that we do have in the Health Equity Department some research that we're conducting, and I mentioned how important research is earlier on. And so we have a psychosocial support needs landscape analysis in the works right now. We are learning from members of rural communities, Hispanic and Latino communities, as well as Black and African American cancer patients and caregivers about what the term psychosocial support means to them. Do they even like that term? In addition to what it means, what can be done better, what maybe should we stop doing? And from there, we're going to develop a best practices guide on providing support and addressing those barriers, some of which we mentioned earlier in this talk. And we are going to not only share that with our network partners, but also our healthcare organizations and other external stakeholders to ensure that the voices and the time being spent sharing what is working, what is not working in terms of psychosocial support is actually implemented. A bit of a mouthful there. Next slide, please. We are also, I just want to call attention to our Cancer Disparities Toolkit, which is hosted on our website at the Health Equity and Action section. I mentioned not only having important research, but advocacy. And when you're looking to advocate for a cause, you need to, as you know, be able to refer to statistics, data that is already available. I love that you can sort this not only by populations. You can look up, let's say you wanted to know more about Black and African American cancer patients, but you also wanted to know about Black and African American cancer patients who have colorectal cancer. You can do that through the toolkit and then have a lot of different statistics populated with their source citations. This data set is available to not only help us advance health equity, but also advance policy. Next slide, please. In addition to that, CSC has our very own research and training institute, also known as the RTI. And something that I want to highlight that I mentioned earlier, some of the data that I pulled from is our cancer experience registry. We have over 50 cancer diagnoses represented in this. The average person has been diagnosed in the past 4 years. We're looking at things like patient emotional distress, financial burden, social supports, treatment decision-making and adherence, as well as the quality of and access to care, really touching on those health-related social needs there, and specifically interested in information about trials, testing, and screening, as well as health-related behaviors. I'm really, really proud of what RTI has done. They work in concert with Health Equity on proposals, and the data that we pulled from this registry is immensely helpful. Next slide, please. We finally also have our very own Action Center and Cancer Policy Institute, also known as the CPI. So at the Action Center, which I'll link a little bit later on in the deck, you can learn how to become an advocate yourself, although I know for this audience, a lot of folks are already advocates, but if you wanted to share with someone how they can become an advocate, this is where you can do it. You can join CSC's grassroots network and also review our legislative priorities. Next slide, please. Speaking of legislative priorities with the CPI, you mentioned HR 2474 earlier, Rose. That is one of our top priorities, as well as making sure that we have oral parity, that there's diagnostic testing reform, step therapy reform. You can go on our site and learn more about what our tenets and pillars are. But also, I just want to note that we're not only working with those with jurist doctors and policy experts, but we really do value and highlight the patient voice, working with patient advocates and the caregiver voice. It doesn't make sense to talk about advancing different legislative priorities if you don't actually have people in the room who have this experience. Exactly. And I'm sure that you can attest to that. Next slide,
absolutely. Earlier, I just want to share something. There's a little movement going on right now called Share the Mic, which is one of the things that we try to do with the CPAN advocacy chat is let other organizations share your knowledge. But there's a movement backing what you just described. Not only do we want experts, we want the people who are experiencing the situation to be the one talking about it. So I think that's really, really powerful. We need the experts, but we need the patients that have lived the experience, the caregivers that have lived the experience. We don't always need someone else telling the story about the patients they treat. Let the patients tell the story. Let the caregiver tell the story. So thank you, Audrey.
100% agree. Next slide, please. So these are some of the resources that I mentioned. They're hyperlinked here. So if you'd like to learn more about our CPI, you become an advocate with CSC, want to see the data in the Cancer Disparities Toolkit, and if you would like to complete our Cancer Experience Registry as a patient or a caregiver, please go ahead and make your voice heard. It is free to complete the registry and the link is there. Last slide, or the next slide is just if you were excited, wanted to make sure you have those sources for your own reference. And finally, my contact information. I would love to have follow-up conversations. I saw the question in the Q&A come in about the health equity and grants. I'm happy to follow up on that more with you one-on-one. My contact information is there, but I'm also, I'm realizing that I was remiss in not including my email address. So I'm going to go ahead and put that in the chat. My apologies.
It's there. It's on this slide. A Davis at cancersupportcommunity.org.
Oh, okay. Yes, I'm looking at a different slide. Okay, great. Thank you. It's there. if anyone has any questions, or Rose, I'll turn it back to you.
Audrey, thank you so much. I loved, your opening, giving the example of a bicycle. And I think anybody who's ever been on a beach vacation, when they have those free bikes, good luck finding the bike that's right for you. So, so I thought that was a great example. Thank you so much for your knowledge. Can we go to the next slide, please? We have one final slide. And this is something that is another very hot topic. Audrey's topic today was about health equity, very valuable learning. A subtopic within health equity is also clinical trials, but clinical trials also stands alone because we know that we want more patients to have more access to the latest treatment, and clinical trials is one way. So again, Audrey, thank you so much for sharing your time and talent with us. And all of you, please join us on Wednesday, May 17th, where we'll be talking about clinical trials in the community oncology setting and the positive impact that clinical trials have on patient care. Thank you all and have a great day and a great week. Thank you.
Thank you.